Hi, everyone. Welcome back to another episode of Beyond the Script. Today, we are here with Dr. Garrick Mok. He is an emergency physician, trauma team leader, and deputy chief of the emergency department at St. Michael's Hospital. He is an assistant professor in the Department of Medicine at the University of Toronto, and he's here with us today. Thank you so much for being here.
Thanks for having me here.
I would love to know, first, what is being a trauma team leader? What does that really mean, and what are you responsible for at what moments?
Yeah, it's interesting. If you kind of visualize how the emergency department works, we have the emergency department, which will see all the patients that come to the emerge, and then we have a separate trauma team as well. So the way the systems work in Ontario is that you have designated trauma hospitals.
Okay.
St. Mike's and Sunnybrook are the two level 1 trauma centers within the city
Wow.
that we have. And from there, you'll have a specific trauma team, which will comprise of general surgery, orthopedics, anesthesia. We also get respiratory therapists as well as the nursing team that comes by. And then we actually add in social workers and spiritual care that comes in for these traumas as well. And then my job as a trauma team leader is that when I get paged, I'm the person that's kind of orchestrating the team or the quarterback of the team.
Wow.
So we respond to all the traumas that come in, whether they're from the street or if they're from a community hospital that sends them to us afterwards.
How often does that, is that like multiple times a day? You're dealing with someone coming in and you're having to manufacture everyone and tell everyone what to do? Yeah,
so we have around 1,500 to 2,000 activations a year. So if you think about around 6 or 8 per day when it gets really busy overall. And then we usually do either 12 hours or 24-hour shifts, depending on kind of your schedule of what you want.
Wow.
So typically what happens is you get the page and you want to get there as soon as you can, hopefully within the next couple of minutes.
Yeah.
And then you have different levels of how sick patients are. You have anything and everything from an elderly patient who fell and has some rib fractures to your gunshot wounds and stabbings that come in as well.
Yeah.
And they can really vary from how sick they are to requiring an operation immediately to just being admitted and observed for some pain management and things like that.
And I would imagine you have to kind of figure out which one is a priority in terms of how to deal with how sick they are, I guess, and how to know who to tend to first.
Yeah, exactly. So our trauma bay has, we can run 2 traumas at once, and we even have the capabilities of running 3 at once if we really need. And for whatever reason, traumas like to come in pairs a lot of the time, so you will get often, multiple traumas that come in at once, even if they're not from the same scene. For whatever reason, I don't know why that happens. 2 car crashes want to happen at different parts of the city and come in at the exact same time, and I don't know why. But when that happens, you often have to prioritize your resources that you have. Thankfully for us, our emergency department, the trauma bay is attached to the emergency department. So if we ever need more resources for our emergency physicians that come in, we always have help that way. But we always practice and simulate these as well. So what we end up doing is we do roughly quarterly simulations overall with our teams, and that involves not just emerge, but really broadening outside. So anesthesia, ortho, general surgery, ICU, they all come down to these as well. And we really try to practice together because we really do need to figure out how do we allocate resources accordingly. And then from kind of my standpoint, it's going to be how do I prioritize which team members I'm going to allocate to doing certain things, which ones go to scan first, which ones can stay for a bit longer and things like that.
How are you able to make those decisions so quickly? I would imagine some of them have to be made in seconds.
Yeah, it's a good question. I think whenever you make these decisions, the benefit is that you never have to do it alone. Right? So as much as I'm the person leading the trauma team, I really err on my team members to really come up with decisions together. So we always have a trauma surgeon that's available as well. So really working together as a team to ask ourselves, okay, we have 2 patients here. I think this one is sicker based on what we're told. I'm going to prioritize these resources to this patient right now. And this other one here who's less sick might wait a little bit longer, or we might kind of prioritize other parts for that patient as well. So a lot of it comes down to just asking the team if they're also in agreement with it. I think especially starting off, you don't ever have to make these decisions by yourself. You can always work with your team members accordingly.
So what actually happens in the first 60 seconds when a trauma patient comes in?
Yeah, it often depends on how sick they are. We have patients that are very sick where let's say they've already lost their pulse on scene and they're being transferred over immediately, and we have to really jump on the patient and start a lot of interventions. And then there's also some patients that are less sick, right? Let's say you got into a car crash, but you're relatively stable, but you're brought to us based on various kind of criteria that you meet. We can take a little bit longer and transfer them over, get them some pain management, get them hooked up to the monitors and do our primary survey. But what we really try to do is what's called like a pre-brief if we can as well. So basically we get notification of these patients coming in at least a couple minutes prior from the scene most of the time, unless they walk in themselves.
Yeah.
And we really try to prioritize and do a bit of a pre-brief with our team accordingly.
Okay.
So personally for me, I often will give, a bit of a preamble of saying, we have a 30-year-old male who came in, shot to the chest.
Okay.
He has no pulse right now.
Yeah.
My priorities for this patient, so anesthesia, I want you to prepare to intubate this patient.
Okay.
General surgery, I want you to get ready to put in chest tubes on both sides. Orthopedics, I want you to help out by putting in an IO if we need. And then we need to get space for the nurses to do IVs as well. And then I want the emergency doc to help me with an ultrasound. So then I'd say we want to try to get that all done within the first minute or so when the patient comes.
Wow, the first minute.
Yeah, so we want to try to do that as fast as humanly possible and make that decision of what we need to do next.
Yeah.
And at the same time, we're also calling for our clinical assistants to get blood for us from the blood bank and our porters to get everything ready.
Yeah.
And then lastly, it's also our charge nurses calling up to the OR and calling to the ICU to let them know that this is all happening. So trying to kind of orchestrate everything we can before the patient comes in so that in the first 60 seconds, we really know right away, like, what's our next step going to be for them.
Yes. Wow. That's crazy. I can't imagine having to make all those decisions and all of it happen so quickly. It sounds like generally things go as I guess people do what you need them to do in that moment. Like, it sounds like you guys are a well-oiled machine. Is that pretty accurate? Or sometimes a patient comes in and what you prepared for is not going to be as helpful?
I think that in a perfect world, everything would go exactly as planned.
Yeah.
But we live in the real world, right?
Yeah,
Where
of course.
there's going to be things that happen.
Yeah.
Blood might not come as fast as we want.
Yeah,
IV access might be difficult to get.
Right.
The IO might be difficult to place. The patient could have anatomical challenges with certain things.
Yeah.
And that's okay. I think that's just the reality.
Yeah.
What we really pride ourselves in is just having closed loop communication.
Yeah.
We understand that things are going to happen, and we understand that things might not happen perfectly.
Right.
But as a leader, my job is for you to relay that information back to me.
Right.
So if the nurses are saying that, Garrick, we can't get an IV in this patient, then I need to have that contingency plan of,
okay,
orthopedics, can you help with an IO?
Yeah.
If they're having difficulty, then we're going to have our anesthesia colleagues to help out.
Yeah.
So we really try to have, plan A, B, and C for every single thing that comes through. Just because nothing ever goes perfectly to plan. And that's just kind of the reality.
Of course. That's amazing to me that you're able to think on the spot, okay, that's not an option, we'll do this one instead. Like, obviously you trained for years to be able to do that, but it's still very, like, especially in just a traumatic situation, I can't imagine being able to just, okay, plan A isn't going to work, plan B, we'll go to plan C and be able to allocate everyone again. That's really interesting.
I think it comes down to actually just practicing as a team.
Yeah.
Like one of my colleagues and mentors, Dr. Petrosonak, always talks about how sports teams practice.
Yeah.
Right? That's what they do all the time.
Yep.
So why are we any different in the emergency department and trauma?
Yeah.
So we really try to simulate these environments as best as possible. And we have a great simulation team that has really high fidelity mannequins and has all the equipment available.
Yeah.
So we really try to work on all these processes because we know that these are really sick patients that need the best care possible.
Yeah.
So we got to practice and we got to train for it. That's
really interesting. I feel like, I certainly didn't know that it's so choreographed in a way, that it's so practiced. I feel like people see, unless you're in the ER, I feel like people see in TV, and that's obviously not a good representation, but it looks like patients come in and then you guys just do what you need to do in that moment. But I feel like people don't think about the fact that it's been practiced many times, which is good, as it should be.
Yeah, exactly, because we know that processes, like the hospital is so complex and patient care is so complex.
Yeah.
The hard part is patients aren't black and white. There's always some kind of gray area as well. So we want to try to work on all these environments as much as we can in these scenarios as much as we can.
Yeah.
And even before trying to practice, we have something called a massive hemorrhage protocol, or MHP. But the process of getting blood down to the emergency department has lots of intricate steps to it.
Yeah.
Right? How do you actually get someone to physically walk up, grab it, and bring it down?
Right.
What if they actually are no longer in the trauma bay and they've been moved to the CT scanner or the OR? How do you communicate that accordingly?
Yeah.
So these were all practiced through simulations with our team. And we did this for things like our code crimsons, which are the patients who need an OR within 15 minutes or they're at risk of dying.
Yeah.
How do you actually get a patient from the trauma bay up to the OR at 4 o'clock in the morning?
Yeah.
When you have to think about the resources that you have that are in-house.
Yeah.
What's the kind of necessary steps that you need to take to practice all this before we can really roll it out? Yeah.
Wow. Is the ER always chaotic, or do you think that's kind of a misconception?
I think where I work at St. Mike's, it's a little bit different than some of the other emergency departments. We're really in the downtown core.
Right.
And around 20 to 30% of our patients are patients who experience homelessness. So we have a lot of social difficulties within our emerge that we have to deal with.
Yeah.
And with that comes with a lot of a lot of challenges as well, right? We're seeing a lot of substance use that comes in through the department. We do see a lot of patients who leave without being seen and then come back afterwards, or they can't really complete their therapies as much as we want because of social situations.
Yeah.
So certainly our merge is a bit chaotic in many ways.
Yeah.
But I think that for the general public, they should know that the emergency department is a place that if you need help, you can get.
Yes.
Right. And I think that's really, really important as well.
Yeah.
As chaotic as it is, if you're very sick and you need help, please come in and we're ready to help you.
Yeah. Wow. Are you able to see patients from beginning to end, or is it usually you see them when they come in and then you refer them to another specialty and you sometimes don't know what their outcome was?
Yeah, so that's kind of the best and the worst part of emerge in some ways, to be completely honest. So when we are able to see patients from beginning to end if we end up discharging them. So let's say you're someone that has a urinary tract infection and you come in, we can see you, give you antibiotics, and discharge you home. Yeah. But there are other patients who might be more complicated. So let's say you come in with a fall and you have a hip fracture. Yeah. I can diagnose a hip fracture, help you with your pain management for that, and then consult orthopedics, and they'll kind of manage it going forward. Yeah. What I do personally is I do follow up on my patients personally. I will call them at times to ask them how they're doing and just make sure. Yeah. I think that's important because you want to build that connection with the patient.
Yeah, definitely.
And I think that's one of the hard parts of merge sometimes is you feel like you see them, they go, and you never hear from them again. Yeah. But there are times where you can really build that connection and that bond and really understand, how are you feeling? We discharged you a couple of days ago. Are you doing okay? Yeah. Kind of go from there.
Yeah, that's huge. That's really good that you do that. I'm sure it means quite a bit to the patients because they might not expect a doctor to do that necessarily.
Just make sure you call not on your personal cell phone number, and then everyone else gets
There you go. Yes. Have there ever been moments when a case comes in and you've questioned if you'd be able to handle it and kind of do everything that you need to do?
Yeah, for sure. The hard part about emerge is that you have to know a little bit about everything.
Yeah.
And you can only be an expert in so many fields, right? So thankfully for me, we have colleagues that are able to help you out if you ever need help with something. And that's 24/7, which is really helpful. Yeah. I remember I had a patient one time come in, they overdosed on a medication that was really, really dangerous. Yeah. Now, they weren't showing signs right away of toxicity, but it was something that if you don't manage within the first hour of ingestion, they can get very, very sick. Yeah. So we need to do a certain procedure, which is called gastric lavage, where you basically have to put a tube into someone's stomach and irrigate the stomach and pull all those pills out that they took.
Is that what they call pumping?
So that's like the term, pumping your stomach.
Yeah.
But the general public doesn't realize that we actually rarely do that.
Oh, yeah.
I know everyone thinks that, I drank too much alcohol and therefore going to pump my stomach. That's not really what happens in real life. Yeah. So to actually grab those pills out the stomach is something that I've never actually done before. Okay. So I remember asking one of my colleagues who's a toxicologist, and they were able to actually call me on FaceTime to kind of walk me through how to actually do this procedure. Yeah. And then we were able to do it successfully. The patient did well. We got all the pill fragments out that we needed to. Yeah. And they certainly did way better than they would have if I didn't have that help. So I think starting off, and even probably 10, 15, 20 years down into the future, there's always going to be cases that you don't exactly know what to do. Yeah. And that's okay. The whole point of medicine is to have colleagues that you can call on and ask for help. And at St. Mike's, we're very lucky. We have consultants that are great and are able to help us very quickly if we ever need.
That's cool that you can ask for help. You're a doctor, but still doctors need to ask for assistance and ask for help. And it's interesting. Now we're able to FaceTime even from someone upstairs or in another wherever and they can walk you through it. That's really interesting. You were talking about being unsure of what to do sometimes. Has that happened in a moment where you had to just make a decision really quickly and you hope that it's the right one?
I think that happens every day, to be honest.
Yeah?
You only get bits and pieces of the information whenever you're working emerge or you're working trauma, and you have to do what you think is best at the end of the day. And you live with that decision, right? Whether it's the right decision or the wrong decision. Yeah. And all you're trying to do is grab pieces of data to help you make that kind of decision accordingly. Yeah. And whether that's from the patient information, whether that's their chart, their presentation, their blood work, or your colleagues to really say, okay, everyone, this is what I think we're going to do. What do you guys think? Help me out here a little bit. Yeah. Right? And I think that happens every single day, no matter what. And we're never 100% sure on anything. Sure. I think the thing is there's no 100% test for anything either. Yeah. Let's say someone gets a full body CT scan, there's still going to be percentage of misses from that no matter what. Yeah. So we really have to kind of piece all the information together all the time.
Yeah, and just do it as best you can.
Yeah, and I think it comes to So if we think about like a trauma situation that comes in, we think about really when someone comes in as a trauma, there's certain places that you can die from, right? You can die from, let's say you get into a really bad car accident. The places that you can bleed or die out from are going to be if you have a really bad head bleed, if you have a really bad chest bleed, your abdomen, your pelvis, your long bones, or any obvious kind of vascular injuries that we can see externally. Okay. So really what goes on in my head is I ask myself, okay, of those areas, what can I manage with right now? And do I need to intervene right now? And there's always a kind of balance between being paralyzed by your decision versus just making the decision of what you need to do. Okay. So for me, for instance, when I think about someone that comes in as a trauma case, if they're really, really sick, let's say they don't have a pulse. I know from the brain perspective, they need to get a CAT scan of their head at some point in time, but that can't happen right now in the trauma bay. If it's their chest, I'm going to say, okay, they could be bleeding out from their heart or they could be bleeding out from their lungs. They could also have lots of air trapped in their lungs. Let's just decompress the chest by putting in chest tubes, regardless of what the ultrasound, the x-ray shows, because if I take 20 minutes to think about this decision, it can be too late. Right? Same with the abdomen. Let's do an ultrasound to see if there's any blood. And the pelvis, let's just put a binder on there to tie it up so that if there is any bleeding from it, we can say that that's not the case. Right? So you don't really have all that information right away. But you have to make these decisions or else you get paralyzed and the patient can't get the care they need.
I guess you train and practice learning how to deal with the pressure of that. Does it become easier to deal with, or is that still something that you have a hard time with?
Yeah, I think so both are true. When I started off, it's really, during residency, it's really finding those mentors. I remember one of my main mentor in Ottawa always said you should have like it's like the UN council of your mentors of different things, right? You have your academic one, your clinical one, your life one, etc. And for me, for clinically, I had lots of different mentors, and you really build, different parts of your practice based on that, and you start building confidence based on, those parts of practices that you like from them. And then from there, I also have one of my colleagues coins this term, like failure friends. So like I have a couple people that I always call when I have a case where I'm uncertain of what I did. Did this go as well as it could have been? What would you have done differently? And I always tell them, give me, kind of the blunt truth.
Fair enough.
And it works well when you have mutual respect with each other and you really take their opinions and you really want to learn from them. So I do that pretty often.
No, that's good. That's a really good label, I guess, failure friends. That's good that you have those people you can contact and talk with and whose opinion you really respect and who will tell you honestly. And
we're all here to grow and learn, right? No one's ever the perfect anything.
Of course,
So it's always good to help.
Are there, I assume there are, but how do you deal with moments that go from a life or death situation to then just walking into the next patient's room and speaking normally and just talking about mundane things? Do you have to deal with that sometimes?
Yeah, it's hard. It's really hard. I think there are certain cases that will stay with you. And when that happens, before seeing that next patient, it's actually better to just step out for a little bit of time. I remember we had a very, very tragic case where it was a pregnant trauma patient, unfortunately, and both themselves as well as baby ended up passing away. And when that happened, we just had to leave for like 20 minutes. We couldn't see anyone else. We called an extra doc in to start seeing some other patients because the whole clinical team was just not ready for it right away. And that's hard, right? Those are really hard cases. And at the end of the day, we're all human.
Absolutely.
And I think it does come with a bit of time and experience where you, as morbid as it says, get a bit more used to it. But then you do have to remember that the next patient you see deserves your time. Right? So until you're ready to go back in, I think it's good to step out. And then when you're done your shift, you find whatever you need to help you kind of unwind and unload.
It's good to hear. I think people would appreciate hearing that you guys have to step away sometimes because you can get emotionally invested, and especially if it's something so traumatic, seeing a pregnant woman with her baby and both of them passing, that's a horrible thing to have to deal with and witness. And I think it's good that people hear that you don't necessarily always just perk up and go right into the next one, because that can seem a little less humane, I guess. So it's good for everyone to hear you guys are still human and it affects you for sure. So do trauma cases ever, well, you just said, I guess, that some of them do stay with you. Do you remember them like years later and you still think about them, or is it more of it'll stick with you for a little bit, and then you're able to kind of move forward.
Yeah, I think every tragic case does stick to you, whether you cognitively think about it or not. It affects the way you interact with your next patient, the way you interact with the family members going forward. And it helps kind of ground you as well in some ways. I remember I had a very unfortunate young patient who ended up being stabbed and passed away. And I remember all the parent wanted was to know what happened, right? What happened in the trauma bay? Did we do everything we could to help that patient? Yeah. And I remember that interaction really, really resonated with me because I had this happen again a couple years later, unfortunately. And same thing, that family just wanted to know that the team did everything they could. Yeah. And I remember just giving that patient's family a hug at the end. Yeah. And it was probably one of the most powerful kind of moments because I remember it was me, it was the patient's father, their mother, their aunt, and their cousin. And it was just I was crying. Like everyone was just crying and hugging because at the end of the day, we lost a very young life and we tried everything we could. Yep. But for sure, those cases, you don't forget them. Yeah. But you try to learn about what you could do differently for the next one. Yeah. And it might be that everything went well medically. It was just an unfortunate event. But you might learn that the way you communicate with the family could be, a certain way at certain times. So I would say we learn a lot from every case.
For sure. I don't know if this would be what you just talked about, but have you ever had a case that kind of changed the way you practice medicine?
I think...
Or the way you view it even?
Yeah. I think I think that case where I saw how powerful it was to just be a human and hug the family members. Yeah. Now, I'm not saying that everyone needs to go and hug all their patients, nor am I, nor am I doing that on an everyday basis. Sure. But I think that there are times where what the family members want when you're communicating such tragic news to them is more than just the physician, but also just the human. Right. Like, I learned this from one of my colleagues where if they're going to deliver terrible news, they always ask if they want something to drink. Like, do you want some water? Do you want some coffee? And just being a bit of a normal person. Yeah. Right? Yeah. Sometimes you got to take off that physician hat a little bit and remember that at the end of the day, this is a family that you're talking about a really, really terrible event. Yeah. So I've changed a lot that way, or in some ways that way as well. Yeah. Where it's okay to sometimes take off the physician hat. Yes. There's a time and place for all that, and there's also time to just be a good person and try to help them where you can. Yeah, I would imagine that part means so much to the families, and knowing that they're just talking to a person who's able to kind of come to their level and communicate the best they can what happened. Yeah. What do you think is the hardest call to make as a trauma leader? I think the hardest call to make is when you make the decision to stop, right? Yeah. I think that everyone wants to do everything they can, but the question you have to then ask yourself is going to be, what's the next step for them? So we could go as far as, let's say, someone got stabbed to the chest. We can open their chest. We can sew the heart up. Yeah. We can give you all the blood in the world. But if you've been down for 20, 30 minutes now, when do we stop? Yeah. When do we say that even if you had any type of recovery from this, that you have now been deprived of oxygen for so long that your quality of life will not be sustainable, right? How do you make that kind of decision? Yeah. Now, I would say that I never had to make that alone. Yeah. I always ask the team, and I say, all right, everyone, this is where we're at right now. Yeah. We've opened the pericardium. We've relieved the tympanoid. We've been able to close the heart. Yeah. We've given this much blood, et cetera, et cetera. We're still have no cardiac activity. Yeah. It's been 30 minutes of downtime now. Yeah. I think it's probably best that we stop. Does anyone have any objections? Okay. If any of you do, please let me know. Yep. Happy to continue or happy to have this discussion, but let's have this kind of discussion right now. And does that happen? Do people have objections or different ideas? It's pretty rare to have full objections, but there are times where people will say, okay, can we try doing this one procedure? And then if there's no objections to that as well, then I think it's very reasonable. Sure. Yeah. Does that happen, I don't want to use the word often, but are there times where a patient is down for 20 or 30 minutes and
you do have to unfortunately make that call? Is that more rare, or does that happen more than we would like to admit?
It's more common in the summertime than it is in the wintertime. There's actually
Really?
a seasonal aspect of things. Yeah.
Oh, can you explain that a bit?
Yeah. So I think when it's warm and nice out, people are outside more.
Yeah.
They ride their motorcycles, e-scooters, cars, etc.
Fair enough.
People enjoy going out and partying in the city more in the summertime.
And,
Exactly. So whenever you mix alcohol, drugs, vehicles, there's always badness that happens.
Sure.
So we definitely see it more in the summertime than the winter. And this kind of, it even compounds during events, right? So we see Caribana is a very popular time for trauma events to occur.
Okay.
Whenever there's parades, festivals throughout the summertime, we see a lot of.
Yeah.
We certainly are thinking about it a little bit during the World Cup. Like, do we need to up staff? How do we kind of prepare for the influx of people that are coming into the city as a whole?
Wow.
There's a whole emergency preparedness team that's really looking at all of this. So it's a lot of these little systems things that we have to think about.
Yeah.
But I would say that it's fortunately not very common that we have to pronounce patients and have these occur. But I would say it happens, unfortunately, too common as well.
Yeah. Wow, that's so interesting that it's good, and it makes sense that there are all these little things that happen behind the scenes of, this event is happening, how can we prepare for it? I never would guess that there's a team of people trying to figure that out. It's great because they're trying to just keep their city healthy and everyone okay and be prepared for what they need to be. But I'm just finding this really interesting, hearing about all the different things that happen behind the scenes.
I'll never forget, we had so Code Orange is it's a term you use for like a mass casualty event.
Okay.
And we had to have a Code Orange planning meeting about the Taylor Swift concert.
No way.
Because we said, what do we do when you have all this influx of people coming in? And then we were like, realistically, it's going to be teenagers and their mothers that are really here. I think we're going to be okay, but we do need to plan for all the Swifties. What do we do with all the glitter that's everywhere in the sequins?
Yes, honestly, that takes over the city.
Yeah, it was an interesting weekend.
Yeah, what would you need to what's something that is maybe more likely to happen?
I think when we thought about this, if the Blue Jays were going to win the World Series, which unfortunately we lost.
Yeah.
But I remember the Raptors parade when that happened. There was a Code Orange during the celebration parade itself.
Okay.
So we did have to just think about how do we prepare for this overall.
Yeah.
So we actually have 2 Code Orange simulations that we run per year, and one of my colleagues is the one who kind of heads this whole kind of program within our department. So we really look through all the processes, make sure that we have all the equipment that needs to be had. The communication, whether that be walkie-talkies versus text messages to each other, or like Epic Message that we use.
Yeah.
There's all these different kind of tools that we can think about.
Yeah.
So we try to practice this all and simulate this all so that if this hopefully never happens, but if it ever does, that we're ready.
Wow. Thinking about the Taylor Swift concert, that's cool that you guys think Raptors it.
We did not get that many Swifties that came in.
Okay,
So
that's
okay.
good. That's good. But is it the idea of like if the Jays had won, or when the Raptors won, is it the idea of people are in the streets, people are maybe getting a little violent, that kind of thing? That's what you look
it's basically whenever you think about a mass gathering of humans with alcohol,
fair enough,
plus or minus drugs,
okay,
then there's always a higher risk.
You need to prepare for it.
Yeah.
Wow.
Even at a Taylor Swift concert.
You never know. That's so funny. Have you been in a situation where you've just been out and you've seen an accident happen and you've gone to assist, or has that never happened?
I actually haven't had that happen, but
Yeah.
people have asked me what I would do if I was driving on the highway and I saw something.
Yeah.
I would stop, but then I would let the paramedics do what they do best.
Sure.
Right.
Yeah.
I think that sometimes you could insert yourself in a situation where you're actually not the most experienced person there.
Yeah.
So I would. If I were to have this happen, I would offer help, but I would also just let them do what they normally do.
Yeah.
But I haven't, thankfully, had this happen.
Yeah, hopefully. Have you, I guess, what would you want people to know if they are a bystander and they are witnessing something happen? What do you think is the best way a normal person could help?
Yeah, so I mean, call 911 is the first thing to do. But I do think that from a community advocacy perspective, everyone should really learn how to do CPR and how to use the Stop the Bleed program. So those are 2 types of different programs that should really be offered to kind of community members everywhere. CPR probably being the most important thing for all kind of students and the community members to know.
Yeah.
Because if you know how to do those basics, that can really save someone's life while you wait for the paramedics or anyone else to come in.
And the CPR, as from what I've heard, it kind of buys time.
Yeah.
Is that right?
Yeah. So kind of from a personal story of this, my uncle had a job interview one time. It must have been a very stressful job interview because he ended up having a cardiac arrest. And the bystander started CPR, put an AED on him, they shocked him,
Yeah.
and then he got brought to the hospital, and he got discharged around a month later with an ICD, and he's doing perfectly fine.
Wow.
And I know for a fact that if that person didn't do high-quality CPR, that he would not be able to see his daughter graduate from high school and university and go into law school and everything. So it's pretty amazing to see.
Yeah.
And I would say that without knowing how to do CPR, that would never have happened.
That's incredible. Like, lucky that someone nearby happened to know how to do it, because that person was there, he's now getting to live his life, continue to live. So it's a really good message. And you said something along the lines of proper CPR. Is there, I mean, I've heard that what's a common misconception or something that people do wrong when they're performing CPR?
Yeah, so that's really interesting. That kind of segues into a bit of like what I do academically.
Okay.
So a lot of my research work now is looking at quality improvement and trying to improve CPR performance within the emergency department.
Okay. Oh, even within, wow, okay.
Yeah, and I think it's one of those things where we are now at a stage where we have technology that gives us our feedback for CPR and lets us know, are you in target for these various kind of metrics that the American Heart Association and the Heart and Stroke Foundation set out as kind of targets of what you want to meet?
Yeah.
And how do we then actually improve that to make it even better, right? So by starting a bit of this work, we realize we're not where we want to be, but we can actually do some interventions to get to where we want to be.
Yeah.
So implementing kind of like a coach. We have like a designated nurse that will help with CPR feedback. So letting people know, okay, your rate's a bit fast.
Yeah.
You're going a little bit deep. Let's try and slow down a little bit, et cetera, and things like that. We can actually utilize some of the information from the defibrillators that we have to kind of give us this information in real time.
Yeah.
And then we can then also provide summaries to providers afterwards to let them know and kind of debrief with the data that's given. So I think one of the kind of misconceptions is that we think that we're doing such an amazing job at this, but if you actually track the data and kind of see how you're doing, there's probably room for improvement.
Okay.
Right?
Yeah.
From like the community side of things, so I would say that any CPR is better than no CPR.
Sure.
Right?
Yeah.
In a perfect world, you'd be giving high quality CPR, but I would rather you do something than do nothing.
Yeah.
Right?
Yeah.
It's kind of interesting. In other countries, they have lots of programs to help with dispatch CPR. Well, someone will kind of coach you through it. I don't recall if we have that here in Canada or not.
Yeah.
But things like that to just provide something for the patient is better than nothing.
Is it a misconception that an indicator of doing proper CPR is breaking the ribs, or are you able to do proper CPR without breaking the ribs?
I think some of that depends on the body habitus of the patient, to be honest. But I would say that most of the time when CPR is being done, the ribs are going to break.
Okay.
Yeah.
And that's obviously worth it if it means the person lives.
So I think that's an interesting question, though, right?
Okay.
So like the question you asked me before about what's a hard decision to make is often, it's actually outside of the trauma bay. It's actually more in the emerge. When you have to make the decision of, should we be doing all these things? Like putting a breathing tube down, which is uncomfortable for patients where they're at end of life. Should we be cracking your ribs by doing CPR if you have a cardiac arrest? Or should we focus on making sure that you're comfortable at the end of your life?
Okay.
And I think that discussion with family members who haven't thought about this is really, really hard.
Yeah,
right?
I bet.
And I think that when I remember going through my ICU rotation as a resident, one of the most impactful things one of the intensivists told me is that patient autonomy and family autonomy is really important, but sometimes it's really unfair that we put this onus on the family members to decide what do you want to do. Right?
Yeah.
Because at the end of the day, if I was telling you, do you want your mom to live with CPR and a breathing tube?
Yeah.
Everyone's going to say yes.
Yeah.
But it's actually the fact that if we do all of that, with your underlying kind of comorbidities of, let's say you have a very elderly, frail patient who's already having a really, really bad quality of life, on dialysis, using bedbound, etc. Do we really want to make them uncomfortable with the breathing tube? They get agitated, they can't speak. Have them be in lots of pain from the rib fractures when we can't bring them to be better than what their baseline was before.
Right.
How do we have that conversation, and how do we guide patients to making the decision that would actually be in the best interest of the patient at the end of the day?
I would imagine sometimes the patient's family gives you an answer that maybe you wouldn't necessarily do yourself, or that you don't think is best. But when that happens, I guess you have to go with what their wishes are.
Yeah, so it thankfully hasn't happened too often.
Yeah.
But there are times when the patient's just not fully ready to have that conversation.
Yeah.
And there are also times where they're not at that stage yet in the emergency department that they're so unwell that you need to intervene now.
Okay, yeah.
But what I would say that is it's important to start the conversation in the emerge.
Yeah.
Because these patients, when they get admitted, for instance, could deteriorate several days later. Right?
Okay.
So I think that it's part of our role is to really portray what that kind of timeline is going to be for the patient.
Yeah.
And then that way, when the other services have these conversations, it's not the first time they're having it. I think it's really difficult for a family to make that decision in the 5-minute interaction that you have with them in a very loud, chaotic environment that you're in.
Yeah.
But at the end of the day, it's important to start the conversation.
Yeah.
And if they really are doing something that you're fully against, that's when I actually just ask for another colleague to help out. And I run the case by them too to say, okay, what would you do?
Yeah.
Kind of, how, do you think we should approach this differently? Sometimes it actually is involving the ICU team where they come down and they see the patient. They can also continue these conversations. But they just have a different person having the same conversation.
Yep.
But I would say it's not been that common in my kind of field where I've had to make that decision that I'm fully so against.
Yes. Okay.
But I do think that it does happen at times. Yeah.
Of course, yeah. Without sharing any identifying details, do you have an example of maybe the craziest or most unbelievable case that you've been a part of or had to treat?
This is going to sound so boring, but we just had this happen like a couple weeks ago.
Okay.
Where someone came in with a really, really bad blood clot in their lung.
Okay.
And basically, when you have this blood clot in your lung, if you don't intervene, they could die pretty quickly.
Yeah.
And the patient ended up, their oxygen saturations were really, really low. Their blood pressure was really low.
Okay.
They needed to be on these high dose medications to really bring their blood pressure up. And then one of the hardest decisions to make is the decision of, are you going to push this medication to help break the clot? Because if you give something called a thrombolytic, you could help dissolve and break the clot down, but you can also put the patient at high risk of bleeding in other areas too, right?
Okay.
So we made the decision working with the ICU teams as well. And then I think within 3-4 hours, she was actually off of oxygen and she was doing way better.
Wow.
And she was able to be stepped down to the medicine unit instead of the ICU afterwards.
Wow.
So it doesn't sound super exciting, but it's one of those cases where you can actually, I think she was quite young too, so we were able to really help her and prevent a lot of the kind of complications that can occur from having a long-term, from having a blood clot in the lung. Yeah. Because you'll cause a lot of stress to the heart as well from that happening. So there's cases like that. And then the other case I remember was, is actually one of my colleagues' cases I was just kind of involved in peripherally, was a young patient who had something called an aortic dissection. Okay. So that's when you have a tear in your aorta, which is the big blood vessel that leads to the heart. Okay. And I think they were actually just visiting from somewhere and they were having some chest pain. Yeah. And they ended up having this big kind of injury or this big problem with their aorta. And he ended up going to surgery with the cardiac surgery team, got it repaired, and was actually doing perfectly fine. Wow. So those are two cases that I could think about. Yeah. And then if I had to think about a third one, like very Canadian specific or trauma specific, would be, we've had quite a few hypothermic arrests. So patients coming in, a lot of times it's because they've been out in the cold for too long. Yeah. And then they come in with very, very low temperatures. Yeah. And this is in my case, actually my colleague's case, but we've been kind of working together to build this program or this pathway for these hypothermia patients from our emergency department. Yeah. So they ran this arrest for a very long time, and then they actually were able to get the patient onto the heart-lung machine or ECMO. Wow. And then the patient survived and left the hospital within a couple of days. Okay. And it was, to me, just one of those cool cases where you really see the intermingling of the various groups. Yeah. So the emerge, the ICU, the cardiac surgery team, and really working together. I would say the best part about the emerge is really when you see these processes actually work seamlessly. Yeah. So it was really great to see.
Was there a reason why they were out for so long, like consistently, to get to that point of such low temperature?
Yeah. So I can't say for that patient specifically, but I would say that in general, we are seeing a lot more cold injuries in the homeless population. Okay. Yeah. And this is something that our group is going to be studying to really look at the patterns of cold injuries that we're seeing. Yeah. So they'll really range from just being exposed to the cold to frostbite to hypothermic arrest. Yeah. So it's a pretty big continuum. Yeah. Wow.
Have you ever had a patient come in and you've just thought, like, how is this person still alive?
Oh, every day.
Every day?
Well, maybe not every day, but a lot of times I say, wow, how are you doing okay with all this that you have going on, for sure? Yeah.
Can you describe what it is that makes you so shocked that they're so alive?
I've seen some people who come in with hemoglobin levels that are so low that you would expect that they would that they should pass out and really not be alive.
Okay.
That then perk up and do totally fine.
Wow.
And it is pretty amazing that you see the robustness of certain patients.
Yeah.
It is fascinating. Some of the patient population that we see. Yeah.
Is that like adrenaline, you think, that's
honestly,
helping with
I
it?
don't know. There must be something in the water because it doesn't make any medical sense to me sometimes.
Yeah, that's what I was going to ask, if there's like things that have happened that medically don't make sense that you see.
Yeah, for sure. You see certain things where it really makes no sense.
Yeah.
And I remember I just asking colleagues, like, how is this person still okay?
Yeah.
And the answer is always, I have no idea.
Okay.
And then you'll have some patients who do really poorly with the simplest kind of disease.
Yeah.
And you also ask yourself, what is different in like, their genetic makeup that makes this okay or not okay for certain patients?
Yeah.
I don't think we're ever going to answer that.
You're just always learning and always asking questions still. Are you able to decompress properly, do you think, after a particularly difficult shift? Are there things that you've learned that you need to do in order to decompress properly and be able to go back for the next shift and work as well as you can?
Yeah, I think that's one of the hardest parts about any kind of acute care work that you do, whether that be emerge, ICU, trauma, etc. I think it's just, how do you go home and decompress after a really sad case?
Yeah.
Everyone has their own kind of ways of doing it.
Yeah.
For me, it's spending time with family.
Yeah.
Having a nice meal to eat afterwards.
Yeah.
And then really having those failure friends that you call.
Yeah.
I remember, for instance, that case with the pregnant trauma patient. I remember I called my friend afterwards to just really decompress and talk it through.
Yeah.
Our department is also really great. We have wellness leads within our department, which probably the best thing that we do is that we have snacks in our department.
Okay.
Which is like, if you want to make people happy,
I
keep
bet.
them fed.
Yeah.
To do like a Costco run every week or so.
Yeah.
So that's been great. But we organize debriefs with the team and really just allow an avenue for people to speak freely.
Yeah.
So one of our emerge docs is actually the wellness lead throughout kind of U of T for this.
Okay.
And it's been great to just decompress and talk about the tough case.
Yeah.
What are people doing to decompress themselves?
Yeah.
If you really need, you can always trade a shift and take some time off because you needed it.
Yeah.
Accordingly, like my group's great where someone will always help you out if you really need. So
people are understanding of that.
Yeah. Because I think everyone's been through it, right?
Of course.
Our emerge group, you'll have people who are first year in, and then you have some people who are 30, 40 years in, and everyone is able to provide you like an area of an area of comfort of what they like to do.
Yeah.
So yeah.
So I have two more questions. One, you might get this question a lot, and I'm sorry if it's annoying, but
it's about the pit.
It literally is. If you haven't seen it, I'm sure maybe it's like it hits too close to home and you can't watch it, which is totally fair. But I was curious to know if you know anything about it or
I think
if you
I'm
have opinions on it.
I think I'm on like episode 10 of the first season.
Okay.
So I haven't finished it yet.
Okay.
So I don't know what happens at the end of the season, nor do I know what's happening in the second season.
Okay. What are your thoughts from what you've seen?
I think it's like if you take the entire career of an emergency physician and every crazy case that they'll ever see, and you compress it into one shift. That is the pit.
Okay.
Right? So it's like an entire career of emergency medicine into 8 hours. That's kind of what it is.
Yep.
There are parts to the pit that I would say are relevant.
Yeah.
So I would say for sure, unfortunately, like hallway medicine is definitely a thing that we're seeing all the time.
Yep.
We will see acuity. All the procedures that they've done are things that we've done.
Yeah.
Like that's all pretty accurate.
Okay.
But it doesn't happen in that succession where you're not going to get multiple things plus the code orange
crazy
all at the same time.
Yes.
Now that being said, I'm working today, so if this comes in, I'm going to blame you and say
sorry.
That's your fault.
Okay, fair enough.
But I would say there are some parts that are accurate and some parts that aren't.
Yeah. Okay, fair enough. I was just curious. I'm sure you get that question a lot.
It's more accurate than like Grey's Anatomy, I would say.
Absolutely. Have you've watched some of it, or
plead the fifth on that?
That one's fair. That one is crazy, but I have heard that doctors are saying the pit is the most accurate one, which is cool. So just to give people kind of a look into maybe a glimpse of what a day looks, or not necessarily a day, but in some cases
more
that
like
you've
a
had
career.
to see. More sure, like fully a career. That's fair. So lastly, I would just like to know if there's anything you would want all patients to know about ER doctors.
I think the thing to remember when you're a patient coming into the emerge, there's a couple of things. The first is that we're all here to try to help you the best we can.
Yeah.
Right? We hate nothing more than someone waiting 10 hours in the
Yeah.
hallway to be seen.
Yeah.
Like, we don't want it. You don't want it. The hospital doesn't want it. Nobody wants it.
Yeah.
Right? We're all trying to do the best that we possibly can to help you. And we'll always see the sickest patients first.
Yeah.
So if you see that, let's say you have an ankle sprain and you're waiting longer, there is a reason for that. Is that we have to see some of these other ones that are sicker more quickly.
Yeah.
It doesn't mean that you're forgotten, but we're all trying to do the very best that we can.
Yeah.
And the other thing is, I think sometimes people forget that the emerge is actually, it's not a place where we rule in what you have. It's actually like a rule out area.
Yeah.
Right? So you're coming in because you have chest pain.
Yeah.
My job is to tell you that you're not having a heart attack or a blood clot in your lung or something that's more dangerous.
Yeah.
Right? So if you're going home, it actually is a good thing. It means that we've done the test to rule out all the dangerous things.
Okay.
We might not have the answer today as to what's causing this pain that you're having in your chest.
Yeah.
But you can at least rest assured that you're going to go to sleep tonight.
Yeah.
And you're going to be okay.
Yeah.
Now, if it comes back and is worse, come on back right away. And for sure, you'll get reassessed and seen.
Of course, yeah.
But sometimes people say, oh, I came in with this, and you're just sending me home with nothing.
Yeah.
But the answer is really, we're actually trying to just make sure you don't have all these really dangerous emergencies.
Yeah.
And if you don't, then that's great.
Yeah.
We might not have the answer today, but that's okay. You can go home tonight, and you should be relieved that this is not dangerous for you today.
Yeah, and maybe it's it's a good thing that the doctors are sending you home, because it means you're good enough for right now that they trust that you can go home safely and be okay.
Yeah.
Yeah. Well, those I think are most of all of my questions. Thank you so much for sharing all this. This is very interesting. I'm really excited to hear more. And I don't know, emergency medicine is very interesting to me because it's so foreign to me and probably everyone else. So
you're welcome to come by St. Mike's whenever you want.
Sounds great. I'd love to do that. All right. Thanks for watching, everyone. Bye.